Welcome to the Rural American Surgeon. I'm your host, Dr. Randy Lehman, a general surgeon from Indiana. This show is tailored around the nuts and bolts of rural general surgery practice. You will find topics such as practical surgical tips, rural lifestyle, finance, training, practice models, and more. We have a segment called Classic Rural Surgery Stories, where you'll get a feel for how practice in the country differs from the city. If rural surgery is your passion, this show is for you. So, now that the ChloraPrep has dried, let's make our incision. Welcome back to the Rural American Surgeon. I'm your host, Dr. Randy Lehman, and I'm joined by Dr. Michael Roskos, my former program director for the Rural Surgery Tract. I really appreciate you joining us, Dr. Roskos. This is my honor.
It's great to be here, Randy. Thank you for inviting me.
So Dr. Roskos has several interesting connections to rural surgery. Number one, is I met him as the associate program director for the rural surgery track at Mayo Clinic, and he had a long practice at the Mayo Clinic Hospital in Crosse, Wisconsin, which is a place where I did a lot of my subspecialty training, and he helped with coordinating all that. But he's also from a small town in Wisconsin and considers his home to be Independence, and he had a rural practice of his own in that area. And so thank you for joining us. Is there anything else you'd like to share about your background and training? And then what I'd like to hear most is your path sort of back home and what your practice looked like over time.
So my training was obviously in general surgery, but I was very fortunate in that I had an excellent experience in vascular surgery, parlayed with cardiac surgery, and then an exceptional opportunity to work in Children's Hospital in Cincinnati and the Shriners Burn Institute. So I came out of my training feeling very confident in a wide spectrum of practice. I didn't know it at the time, but that helped me in a smaller town starting in La Crosse, but it helps you even more when I was doing surgery in a town of 2,000, which I did on a weekly basis in Arcadia, which is where both my parents grew up, and then all of my extended family immigrated to that area in the 1800s. So hence the roots, which is fun because so many people knew my parents, my grandparents, my great-grandparents coming into my clinic that I felt like I knew them. I had their trust immediately upon seeing them. So it was truly a highlight of my career of 23 years.
Yeah. So what kind of operations did you do in that small town?
So it was mostly hernias, so umbilical hernias, inguinal hernias. I did a couple appendectomies for cases that would come in that Friday morning, and then I would circle back on Saturday to discharge them, again, in conjunction with visiting any relatives that happened to be close by and that, during that return visit. Laparoscopy, open surgery, lipomas, lumps, bumps, pretty straightforward, easy things. No endoscopy in this situation.
Yeah, great. So, it may almost go without saying, but the next question I ask every guest is, why is rural surgery special to you?
So rural surgery is special to me because I was always going to the patients. And Arcadia's 45-minute drive from La Crosse, easy, simple roads. But what I realized early on is so many people not only found it difficult to find rides and transportation there, but downright intimidating. And so if you could do what they needed, see them where they lived, you provided so much comfort to them with their care, especially for somebody they knew and trusted. Probably the most striking interaction I ever had with a patient, as we talked about the need for screening colonoscopy, is that they would rather die of colon cancer than to drive to La Crosse to get their screening colonoscopy. And I realized very quickly that people were compromising their own care because of the fear they had for something that seemed so easy, so simple for the average person.
Yep. Yeah, that's, I think we're all basically living that. So I completely relate. I know you have some great stories for us about some of those patients. Let's get to that a little bit later. But first, I'd like to do the how I do it. So today, we're going to be talking about something that I would say is happening very infrequently in rural America, but it's something that we're all interested in just chit-chatting about. So I think my listener would like to talk about carotids today, which you had a good practice for a long time in La Crosse. La Crosse is what, 200,000 people?
Just north of 52.
Oh, really?
Yeah,
Okay.
so it's small townish.
Okay. It feels bigger to me, but I guess it's just trapped in between the bluffs and the river there. So anyway, but you have Gunderson. That's sort of a bigger hospital, I would say, in that town, and then the Skimp Clinic, which joined Mayo, which is where you were practicing, and carotids happening, vascular happening at both places. And I scrubbed lots of those cases with you and Dr. Curis, and some cases with Dr. Chapman. And I guess I want to talk about the details of the operation and how you guys did it. But I also want to talk about working the patient up. And lastly, the changes that you saw through the decades in vascular surgery access. So where should we start? Maybe let's start with a patient, and who would be the right patient to get a carotid endarterectomy?
Well, in our practice, obviously we the first level of decision was symptomatic versus asymptomatic carotid disease. And as simple as that sounds, sometimes it's very hard to sort out who has symptoms, who doesn't. We took a lot of people who, for example, had vertigo and had to sort out whether or not that was carotid related or not. And some of that was patient driven. A lot of it was primary care driven, who part and parcel with those symptoms oftentimes got a carotid ultrasound. And it makes a difference, obviously, if you're dealing with symptoms versus no symptoms and the degree of stenosis you have. And so I think the patients that benefited the most were those that were symptomatic. And they would have classic symptoms with a degree of stenosis that correlated with something that indicated carotid endarterectomy.
So you're thinking that would be like a 50% stenosis with symptoms?
Yeah, yes, absolutely.
And then the cutoff for asymptomatic carotid disease, we're using 80 for most of the time?
Yes. And so that's where we gravitated to. In training it was 70%. It gravitated to 80%. And even then you have to be a little bit careful. And what was always part of that discussion is here are the risks, and you balance it with the benefits. And it's not just as simple as 80%. No symptoms, let's go fix you. Let's describe the surgery, some of the complications, and decide, does that make a lot of sense for you? Where do you stand, not only from a medical standpoint, but from what you experience in dealing with this as a family or as a patient?
Yeah. And yeah, you don't want to, try to do a stroke reduction procedure and then stroke from the procedure. It's hard to know so you have to have the cutoffs and guidelines and whatnot. So, all right. So you have a patient that they meet criteria for carotid endarterectomy. We're going to jump all the way to the operation. So, there are different ways to do intraoperative monitoring, but most of these you did under general anesthesia, not with the patient awake.
Mine was exclusively under general anesthetic. And I was trained in a program that we had non-shunters and selective shunters with stump pressure monitoring.
And so then you'll take the patient, you're going to position them arms tucked.
Correct.
And are they going to have an A-line?
All of them have an A-line. Yep.
and general anesthesia. And then you're going to position their shoulder roll.
Shoulder roll, absolutely. So slightly
turn the head away.
Yep, turn the head away from the operative side.
And you prep from the just above the jawline to just below the clavicle.
Yep.
And then maybe to the bed. And also, how far do you go to the other side with your prep and your drape?
So we're well over midline, but it's still a relatively small field of ultimately draped area.
Yep. And then where do you place your incision?
So I go along the anterior border of the sternocleidomastoid. So more or less a vertical incision.
How long?
As long as it needs to be. I preferred to make longer incisions. I wasn't going to compromise cosmetic outcome for lack of exposure.
Sure.
So it's a balance.
So anterior border of the SCM, go down through the sub-Q, and talk me through dissection down to the carotid.
After getting through after following the anterior border of the sternocleidomastoid, you were in that carotid sheath. And for me, there was always trying to identify the crossing vein that gave us the best landmark. And again, it was maximizing the exposure of the carotid artery. So it was probably the most important part of the surgery.
Okay. And then with the vein, you tie it off?
Absolutely.
Okay. And then are you going to place some sort of self-retaining retractor?
Yep. So for sure, a self-retaining retractor that just was manipulated as little as possible, ideally once.
Got it. And any other special retractors that you wouldn't do the case without?
Oh boy, that's a great question.
Like a goiter retractor or anything like that? I'm trying to remember. Or did you just mostly use the Army Navy with the assistant?
No, it was so a self-retainer, and we would use an Army Navy, but again sparingly. I was resistant to replacing the retractors too much just because of neurovascular bundles that were in the way, named and unnamed.
Okay. And so you've got the anterior carotid exposed. How much of the bifurcation do you need to expose before you start your carotid endarterectomy?
That's a great question. Again, it's anatomic.
Thank you.
It's an anatomic decision. I mean, there's no reason not to dissect out as much as you can without compromising the surgery. But there are just situations where that's not humanly possible to get the same amount in every person. It was a time of the surgery where I'm going to spend extra time getting more vessel out. And to answer your question, it's enough to get a retractor safely in the place above the anticipated site of the endarterectomy.
Okay. And you don't want to be too aggressive manipulating. I mean, do you go as far as to say it's like a no-touch technique on the carotid, or just when you dissect it out, any little technical tips and tricks there?
Yeah, I mean, it goes back to minimizing the manipulation. And there's some benefit to getting a clamp site figured out first and cleaning up the vessel afterwards. So when you dissect it out, clamp placement is the priority so that you can safely do the endarterectomy. But if there's touching up you need to do, that can be done once the clamps are in place.
So the first clamp you place is a proximal clamp so that there's no risk of dislodging clot or plaque and
Correct.
causing a stroke. I mean, just for the sake of being straightforward and simple about saying it. That being said, I haven't done any carotid since I was training with you guys. So it's been like 6 years since I've done a carotid. So, and I honestly didn't sit there and study the textbook for this interview. So I'm going to rely on you, but I'm going to be the guy that advocates for the listener and asks the stupid questions. All right. So you place your proximal clamp, and that's like a Bulldog or a Satinsky, or what kind of clamp is that?
I used to Gosh, you're going to test my knowledge here
I'm
because
sorry.
it's been 4 years for that.
Yeah.
But it's usually I just use a Bakey vascular clamp.
Okay. And then did you measure stump pressure some in your practice and sometimes not, or how did that change over time?
No, I always measured stump pressure. I think the evolution that took place is what stump pressure you're willing to accept, and then pairing it with visual back bleeding at the same time. So you needed correlation with all those things. For me, a stump pressure 20 or above was kind of a hard stop, left shunt. If there was challenges to be had, say with shunt placement, you could correlate it with back bleeding.
Okay. That means after you do your endarterectomy, you release the proximal clamp and see how much back bleeding you have?
Yes.
Or how do you, okay.
Yes. So once you've committed to your endarterectomy based on the stump pressure, you have the vessel open. You're going to do that in a way that will allow you to check that back pressure. So meanwhile, you're going to have the shunt open on your table. If there's concern, so that once that vessel is open, you can transition to that as quickly as possible.
Okay. And just for the sake of, again, making it really dumbed down, the stump pressure you're talking about is you put the clamp on, you pass a needle in that's hooked up to some sort of a pressure monitor.
Correct.
That's in that superior to your clamp. It's measuring the backflow that should be coming essentially from the vertebrals and the contralateral carotid artery, making sure that there's there's good flow through from the other side to perfuse the brain, so you have time to get your operation done and there's no ischemia happening.
Absolutely. Yep.
Okay. So, and then we just jumped kind of to having the carotid endarterectomy incision open. But what knife did you use to make that incision, and any tips about like how you snaked it around the bifurcation, how far to go down on the common?
Yeah. So I used an 11 blade to get into the vessel, and then used a scissors once it was open to extend the incision site, anticipating how that's going to set up to put your patch in ultimately.
And your patch is your bovine pericardial patch?
Yes.
And you put the smooth side in?
Smooth side in. Although
okay.
The manufacturers will say it doesn't matter.
Okay. Very good. So one thing that's probably not as common is seeing that shunt. So tell me, how do you put the shunt in? Say you have a pressure of less than 20, then you need to make your endarterectomy to place your shunt, right?
Correct.
And so then how do you secure it, and where exactly do you put it? Just if you were telling Jack.
So the key to that shunt is doing so in a way that minimizes dislodgement of plaque. And there's almost no way to avoid the fact that shunt's going to go through that. I put the proximal shunt in first, back bleed, so you're sure that the shunt is then filled, and then the distal part goes in first. The proximal goes in second, and attention is then paid to minimizing all the bubbles, obviously, in the shunt, minimizing that risk of emboli. They're held in place with balloons, and again, exposure is key.
Yep, and you're going to have to basically do your endarterectomy around the shunt. It's in your way now, right?
Yes, absolutely. And it's surprising how little that plays into the distraction. I mean, it actually keeps your visualization. It gives you more visualization than it impairs, strangely enough.
Okay. And so then, say we didn't have to shunt, and now we are just open, and you made your incision with your 11 blade, extended it with scissor, and you're ready to start your endarterectomy. Do you start at distal or proximal?
The endarterectomy started distal, so on the internal carotid. I think it's probably the most important stitch in there. It's the smallest part of the vessel, the area that's most likely to restenose. And so being able to visualize that is super, super important.
Okay. And then how do you start it? So you get behind it based on your cut edge of your endarterectomy?
So I will go outside in on the patch, inside out on the vessel.
Wait. I'm talking about we're doing not the patch, but the endarterectomy, getting the plaque out.
Ah, yes.
Yeah.
So getting the plaque out, I always start on the common carotid artery with getting
That's
the plaque
what I thought.
out.
Yeah.
Yep. And then you extend it very carefully up to the distal endpoint, which also is probably probably the most important part of the endarterectomy. Any flaps you develop there obviously will set yourself up for dissections and troubles.
So if you have a little flap, then you stitch it down?
Yep. I'm a big fan of tacking sutures.
Yeah. And to place that tacking suture, do you come in from the outside of the artery all the way through and then back down? Or how do you, or the knot can't be in the lumen, right?
Right. It ends up being an inside out stitch, double arm suture that obviously you take 2 passes then through the vessel and tie the knot on the outside.
Gotcha. Double arm suture, bring it out, and then tie on the outside. Got it. And then if it gives it to you, you'll take it up the external carotid, just to kind of as far as it's easy to give it to you, the plaque?
Absolutely. Yep.
Yeah. All right. And when we start that endarterectomy, taking that plaque out, do you start at the cut edge of your incision? Like, because you can see the layers of the vessel there?
Yes. Yep.
Okay. And you're using a freer elevator?
Yep.
And what other instruments? A DeBakey?
Yeah, probably those 2 instruments. And that plane is obviously super crucial. And what I found over the years is it shows itself. If you're working hard to find the plane, you're in the wrong plane.
Okay. How can you mess that part up?
I think there's 2 ways. One, too deep, you'll put a rent in the vessel. The other one is, I think if you're too shallow, you get an irregularity in there that becomes thrombogenic.
Okay, got it. So you're basically cutting sort of through the plaque at that point. You
Yes.
don't want to do that. And the intima comes up with it.
The intima comes up with it, yep.
Yeah. Okay, and now you're putting your bovine pericardial patch. You said already that you're using the pointed end of it to start distally on the internal carotid artery.
Correct.
Smooth side in, and you're still using, you said that's the most important stitch. So the patch is on the outside. You're still using your double-armed Prolene?
Yep, 6-0.
What is it? 6-0? Okay. And you're using a Castro, man. Good that we're reading my mind, but it's exposing the time, weighing on Dr. Lehman's mind. So good. You use a Castro, and you're going inside to out on the vessel and inside to out on the patch, and then tying on top of the patch.
Correct. Yep.
And then you're going to run that down each side. Which side do you run first?
I have to think about that one. I think.
Or is it not always the same? It's just whatever looks right.
I think I do my forehand first. So it depends on which side you're using, but I would prefer to do my forehand first. Just because it gets you in, I think, the right frame of mind, gives you a little bit of confidence and flow. And then Yeah, switching to the backhand.
So then when you're coming down forehand, you're going down through the patch, down through the vessel.
Yep.
And then back up through the vessel, back up to the patch, or?
No, it's a running suture. So it's
just like a baseball.
It's like a baseball. So outside in on the patch, inside out on the vessel, and then running about halfway down.
Outside in, inside out, and then run. Yep, got it. Okay. Go halfway down, and you do that on each side, and then what?
Then I'll start a second suture proximally and repeat the same thing.
Okay. And then if you did shunt, at what point do you take the shunt out?
I take the shunt out when you have probably 2 or 3 sutures left.
Okay.
So the shunt ends up being very flexible. You can get out through a relatively small hole. And obviously, because it's a baseball stitch, you can loosen it enough to kind of get things out.
So just take it and put a little, put your clamp back on proximally, finish it up. And then once you get you ran up from the bottom, so you probably, if you had a shunt, you would tie the one side already, and there's only one side that has a few more stitches to go.
Yes.
And then the shunt comes out, and then you put some sort of a catheter or some sort of flush in there so there's no bubbles, right?
So I'll just back bleed and bleed forward. I don't have to put a needle in per se.
Okay. So you let blood sort of fill up behind the patch before you throw your last couple, your tie down your last stitch, I should say, probably. You already have the stitches thrown.
Yes.
Just holding it open. And then you back bleed, tie it, and then come off of everything, right?
Correct.
All right. Did I miss anything to this point?
There's nuances along the way. I think the order of back bleeding is important. Internal carotid first, common carotid last or second, and then external last.
Okay. Fair enough. And then you did some ultrasound after the carotid was then open, right?
Correct. We ultrasounded everybody after the patch is sewn into place.
And so you're looking for nose stenosis, meaning that the velocities are nice and low.
Correct.
And anything else on that ultrasound you're looking for?
I would look for
flaps, maybe.
Yeah, flaps would be the most common thing. And the evolution we learned is that it's really hard to find those flaps. And because of the ultrasound, they oftentimes look much worse than they actually were. And trying to figure out how much the ultrasound helped versus hurt. There's a price to be paid for chasing everything you see on ultrasound and opening that vessel up. So the balance is, are you going to prevent a stroke by going back or causing a stroke by going back?
Yeah. Risk benefit. Here we are again.
Yes, here we are again.
And then for closure, what did you do for closure?
So I closed the probably 2 layers. So we closed the carotid sheath, and then a subcutaneous layer, and then finished up with a foral monochrome on the skin. So
it's not really a named platysma layer when you're this far lateral?
Correct.
Yeah. All right. Very good. Well, I think, honestly, I might have seen you do a carotid faster than we can describe it. But it takes a little bit to use, pictures worth 1,000 words, So that was an excellent description. Thank you very much.
Yes, you're very welcome.
So let's move on to the next segment of the show. It's called the Financial Corner. Do you have any particular money tip that you could share with our listener?
Gosh, I think, the important part of a surgical practice, whether you're part of a multi-specialty group or an independent practitioner, is just getting the coding right. And there are abuses that can take place of overcoding or making up codes. I think at the end, you just have to be knowledgeable and code accurately. And what shocked me in my career is how some of the things you took for granted as simple and easy were significant coding opportunities.
Do you have any examples of that?
Probably like mobilization of the splenic flexure would be one in colon surgery. There were situations, I think, when you had to manipulate like the ilium to get down to a low anterior anastomosis. That was, and I can't remember the details of that, but how you use the omentum in that situation was also a codable.
Omental flaps, yeah.
Yeah.
Sure. Obviously, TAR, can code as a plastics flap. The other thing we've talked about on this show is the codes for laparoscopic common bile duct exploration. There's actually a code for cholecystoscopy that I did not know for like several years. And I was like, oh, geez, add-on code that I could have used. Yeah. And then, just good documentation for some of the basic stuff like your lipomas. If it's subfascial, that's obviously a huge bump in your code, and you need to make sure that you're documenting in that as well as the size, and just not losing out on any of that, because they may default it to subcutaneous if you're using a coder when it's actually subfascial is worth like twice as much.
Right.
Those would be things that I saw. So great.
Yeah. I think the wide local excisions that come along with melanomas were always good. And then knowing how much skin you graft on split thickness skin grafts matter. And I think it comes down to two parts. One is your own knowledge, but I think the coder's knowledge too. And there were situations where, for example, in spine exposure cases where the coders just weren't aware of the procedure I was doing, and it took a little work to go from an unspecified code, which is default, to an actual description. And the RVUs is a factor of 3, sometimes 4 in a situation like that.
Gotcha. Yeah. I guess one last question on this topic is, how would you recommend that a person learn about this? They come out of training. I mean, honestly, I did not realize that what I was putting into the residency code logbook was a CPT code until I was a 4th-year resident. Okay. And I'm like somebody that cares about that stuff. So, how you need to learn about CPT codes if you're a resident, but then when you get out, is there a course or any other thing that you'd recommend?
I never took a course. I took an interest in it only because I tend to be curious about things that I'm expected to provide. Time doesn't always allow that to happen, but I think it's more important now than ever that you take a shot at trying to understand it.
Yep. Okay, great. So the next segment of the show is a classic rural surgery story. I know you've told me some stories before about some of these patients from Arcadia.
Yeah.
And so anything come to mind? Things that an urban surgeon just wouldn't believe.
Oh my gosh. I don't know. I feel like general surgery in general is full of those stories, regardless of where you're at. The one that bugged me the most, and I don't know what category this falls in, but it's some of the frustration that we feel in this environment is seeing somebody for inguinal hernia who has intense groin pain a week after the pain started. And when you examine them, it's pretty clear that they torced a testicle. So a misdiagnosis in an environment that doesn't see that often gets frustrating because they didn't reach out. They didn't understand the limitations. You weren't there every day to bounce something off, and they're very willing to wait for some of those problems until you show up a week later, 4 days, 5 days later. And it's under those circumstances, it's a teaching moment to say, I'm available, call. here's what I would do. Interestingly enough, they have 24/7 ultrasound access. Yeah. So they could have sorted that out. But I think I was surprised by um, people's willingness to live with things that would bug most people enough that they would find their way to a clinic much, much sooner.
Yeah, that's crazy. Did you do an orchiectomy on that patient?
I did not.
Okay.
No, did
somebody?
Somebody did, yes.
Okay. Got it. And the other one that I wanted to say is I think there were some people that they walked to their surgeries.
Yeah, those are my favorite stories. They would literally, they lived within a block or two of the hospital, so they could walk up, get their surgery. Somebody theoretically would walk them home.
Yeah.
But it was nice to know that they were that close to be able to come in and have minimal disruption with their lives.
Yeah.
And it wasn't unusual to do 1 or 2 surgeries every week there. So that not only impacted the people with surgery, but the 10 or 12 people I would see in clinic as well.
Yeah. I want to share one more thing before we get to the resources for a busy rural surgeon and then close it out, that you told me that's always stuck in my mind. When I was a chief resident, I was kind of wondering, like, how busy do I want to be? Like, do I just keep pushing? And, so now I'm operating in 4 different hospitals, right? And all the places want more days of my time. And now when I first went out, I went to just one place that was a county of 12,000, and I was only operating in one place, and there were 2 other people there. Now, granted, everybody's practice is kind of slow, but I had tons of free time. I actually bought a bunch of real estate and set myself up for life, so that was good with my free time. But like I remember at the beginning saying, man, if I don't pick my practice up, I'm going to lose my skills. Now I'm so far to the other extreme of that. And I've gotten to a point where now I can see, if you're at 4 hospitals, why not be at 5? Why not be at 6? And at some point there's going to be a limit. If you can operate 8 hours a day, why not 10? Why not 12? And you told me, let me say this. Dr. Euchre told me I shoot to do 1 case a day. That's one thing he said to me. You told me 40 cases a month and you'll be bored. 60 cases a month and your home life will suffer. Shoot for 50 cases a month. Do you remember saying that?
I do.
But that's variable, because if your practice is colonoscopy, do you count the colonoscopy as a case, right? So then that's the other thing is, if you're doing carotids, a carotid's going to take a lot more out of you on a given day,
right,
than a scope.
Yep, and I didn't do scopes, so I can't comment on that, but it felt like there was internal balancing. If you had a carotid, you might do a 1 or 2 surgeries less that day and more on other days. You're not doing carotids every day, every week, sometimes not even every month. So I think it balances out. I think what counted was in the OR. So if it was challenging enough to be done in the OR, whether it's a patient preference or just a big case, I didn't put the clinic procedures I do into that mm-hmm. category.
Yeah, then there's other ways you could potentially measure your amount of time that you're spending working. You could use hours. You could also use RVUs, which is sort of a neutralizing metric, but depends on how you measure a lot of those things. Second code, is it half or not? And then somebody what I'm trying to do is I'm moving away from clinic, and I have a nurse practitioner who works with me full time, and she's doing a lot of my clinic. What I found in my practice is I can generate around 3 to 4 RVUs per hour in the clinic, but I can generate about 8 to 10 sometimes RVUs per hour in surgery, more like 8. And then when I'm in scopes, it's somewhere in the middle of that. Maybe it's around 6 to 8 or 6 or so. And so if I if I really end of the day, what I'm trying to say is, I don't want to work more than 2,000 hours a year or something, then, or like, that's the limit between being able to spend time with this guy, or, whatever. So that's where RVU doesn't hit you as the right number, and case volume doesn't hit you as the right number. So it's a complicated question. It depends on what your practice is like. And I guess you just, you could shoot for 50 cases a month coming out of training, and then see what your practice is actually like and how you feel.
Right. Well, and isn't the balance, you really want to take on what people give you, but do it so in an honest manner. I think the challenges are the extremes. I think there's a too much there, which I think is hard as a resident to identify because you're used to doing too much. I think there's a lot of I'm not doing enough, which is frustrating because you want to do more, but the less you do, the less you can do. And so I think it behooves you to be willing, especially in rural practice, to take on almost anything, regardless of how fancy and crazy it is, as long as you're comfortable doing it. And the best way to become uncomfortable with doing it is to stop doing it.
Yeah, tell me about it. I'm starting to feel some of that stuff. But the things I remember, I think you and some other people said, now's the time you list everything for your privileges, when you come out of residency, and then your scope of practice generally is only going to shrink. Now, we do have some studies going on, American College of Surgeons and the Rural Surgery Listserv. There's a study that Dan Bacon is putting on. If you haven't done that, please do that study.
Okay.
You and the listener. But it's a study on learning new skills during the course of a surgical career. Yeah. So that can happen. But I would say in general, like, you're going to lose from what you walked out. Like, say you're ready to walk out and do lobectomies, and then now I haven't done lobectomy, or I'm trying to think what other things are that are even simple things that recently I know I had one. Oh, I came out, I was thinking maybe I would do parotids, but there's no way I'd do a parotid now. I mean, it's just, you go out and you realize these things, 1 in 100,000 things, you're only going to see once every 5 years, and you're not really adding a lot of value by doing it.
Right. Yep. And I'll be honest. If you're able to tell a patient you can't do it, and it's because you haven't done them often enough, they appreciate that. You don't lose a patient; you actually gain a patient in having those conversations.
Yep. A lot of times patients ask me also, what else do you do? And then you tell them, and then all of a sudden, the last thing I say is usually skin cancer, and then it's always, well, I got this spot right here, and so there's plenty of other work to do. So great. Any other resources that you have for a busy rural surgeon that's like a resource you love that every rural surgeon should know about?
Gosh, that's was an evolving question. I mean, I really gravitated to UpToDate. It's a little clumsy at times because you get linked through a bunch of different chapters. So it's hard to do in between patients. But to me, that was an exceptional resource.
For cancer, did you use NCCN guidelines a lot?
Absolutely. So that would be the second data set that I used a lot. And I was just shocked how few people actually took the time to look at it. And it was primary care right up through surgeons. And I think it's nice to be able to understand that not only because it impacts your surgery, but it impacts how that care is going to be provided. And I think having that background knowledge, even though you won't give the radiation or the chemotherapy, helps in describing to patients in the context of their options.
Yeah, very good. Well, thank you so much for taking the time to just share all this stuff with us today. I really appreciate it, and just catching up with you. And you just mean so much to me and to my training. You've just, I can't even say like how much you impacted and advocated for me specifically and us as residents, and just being such a great mentor to work with. So I can't say enough praises about you, and I hope you're You're just doing awesome up there in La Crosse, and thanks again for taking the time.
Oh, you're very welcome. Thank you, Randy.
And thanks to our listener for being here. This has been the Rural American Surgeon, and we will see you on the next episode. Don't forget to like us, interact with us on Facebook, share this with all your friends, and we appreciate you very much. And I'll see you on the next episode of the show.